Hi, this is Todd Kramer with Emory Radiology, talking about one of the 22 can't-miss diagnoses for medical students. My hope is that after watching this podcast, you'll be able to recognize some of the common manifestations of pulmonary edema seen on a frontal chest X-ray. Pulmonary edema can be thought of as too much fluid collecting within the lungs. This can happen for a number of reasons, but one common problem is an underperforming heart which causes increased fluid and pressure to back up into the lungs. Commonly, at lower pulmonary vascular pressures, fluid will accumulate in the interstitial spaces, which can be thought of as the parts of the lung that aren't directly involved in gas exchange. This diagram shows the secondary pulmonary lobule, which is the smallest building block of lung anatomy. The interstitial space is represented by the red and green lines at the edges of this building block. At higher pulmonary vascular pressures, fluid can flood into the alveoli. Remember that even though this diagram shows the alveoli as discrete, fluffy brown structures, they actually make up the vast majority of the lungs. Here's the chest X-ray of a person with interstitial pulmonary edema causing curly B lines. Curly Bs, which are sometimes called septal lines, are found at the lung bases at or near the costophrenic angles. Normally, the peripheral interlobular septa, which make up curly B lines, are too small to be seen on a chest film. However, when engorged with extra fluid, they become visible as these short parallel lines that reach all the way to the periphery of the lung. Curly B lines can start to show up when the pulmonary venous capillary wedge pressure reaches 15 millimeters of mercury. Remember that normal is 8 to 12. Here's another patient with curly B lines. Notice them most clearly at the right lung base. Not all curly B lines mean the patient is in acute pulmonary edema. Patients who experience repeated bouts of edema may fibrose their interlobular septae, causing permanent thickening. Therefore, curly B lines may remain even after the clinical heart failure picture resolves. In that case, these lines would be called chronic curly B lines. Here are axial, coronal, and sagittal images from a CT scan done on a patient in pulmonary edema. Notice again how the thickened septal lines reach all the way to the edges of the lung, and how the thickening is more obvious at the lung bases. Here's another finding that is common in patients with excessive interstitial fluid. In this case, the fluid has accumulated around the bronchi, causing parabronchial cuffing. Normally, the walls of bronchi are invisible on chest X-rays because they're so thin. However, just like in curly B lines, extra fluid can accumulate in the parabronchial tissues, causing them to become visible. Notice how there's a dark bronchus in the patient's right lung that is surrounded by extra density. Parabronchial cuffing is best seen when the bronchus is seen on end, when you're looking directly towards the bronchus. When seen on end, the contrast between the air-filled bronchus and the fluid-laden interstitium stands out, looking like a donut. Here's another patient with bilateral parabronchial cuffing. It's more prominent on the right than on the left. In this case, we have a strong evidence to suggest an etiology for pulmonary edema. Notice the pacemaker and automatic defibrillator in the left chest wall. This patient has a third finding that can be seen when extra fluid collects in the interstitium. This is a patient with curly A lines. Curly A's are caused by fluid accumulating in the connective tissue around the more central bronchoarterial sheaths in the lungs. These lines are more central and they radiate from the hilar for several centimeters. Unlike curly B lines, curly A's do not reach all the way to the pleural surface. If you look closely, you may have also spotted some other findings of interstitial pulmonary edema. There are curly B lines at the right lung base, and there is also early right-sided parabronchial cuffing. Here's another patient with curly A lines. Notice again how the curly A's radiate from the hilum and don't go all the way to the edge of the lung. Here is yet another person with curly A lines. However, this patient has another finding of extra interstitial fluid. Take a look at the minor fissure, which separates the right upper lobe and the right middle lobe. Since it runs more horizontally than the major fissures, its presence on a frontal chest film is not by itself an abnormal finding. However, notice that the middle part is a little thickened. That extra thickness may well be caused by pleural fluid collecting in the minor fissure. Now, let's look at some examples of patients with a more advanced pulmonary edema type pattern. First, notice some of the findings of interstitial edema, including curly A lines and parabronchial cuffing. Now, notice how the lungs look more white than normal because of innumerable fluffy, poorly defined densities in both lungs. These densities represent fluid accumulating in millions of alveoli, which limits oxygen and carbon dioxide exchange. Clinically, patients with florid alveolar pulmonary edema have evidence of poor oxygen saturation. Here's another patient with florid alveolar pulmonary edema. Notice again how the lungs appear too white because of poorly defined, fluffy densities throughout both lungs. In addition to alveolar edema, there are findings to suggest interstitial pulmonary edema. Curly A lines and parabronchial cuffing are both present. This patient has also developed bilateral pleural effusions. Finally, here's a patient with numerous findings of pulmonary edema. Test yourself and look for the curly A lines, curly B lines, right pleural effusion, and alveolar edema.